Okay, you can start now.
Okay. Good afternoon.
Good afternoon.
This is Dr. Muzna. I'm one of the baby doctors. I believe I'm talking to Mrs. Rose and Joseph.
Yes, doctor, this is me.
Thank you, both of you, coming over here to discuss about Joseph. And I have received a letter from the GP about the height issues of Joseph. So could you tell me more about your concerns that you have?
Yes, doctor. Actually, I see that Joseph is not growing well. And I am worried because I don't see him happy because he says that his friends are taller than him. And so he's worried, and even I am worried about it.
Okay, I'm really sorry to hear about this, and we are here to help you, Mrs. Rose and Joseph. I'll just make a few points about all the issues you have so that I can help you. Is it fine?
Yes, yes, sure, doctor.
Yes. So besides this, you're telling his height is is less as compared to his peers. Besides this, does he have any issues?
No, doctor. Actually, he has no other problem.
Okay.
When he was fine. Initially, he was fine. But I think from the age of 9 years, I feel that he is dropping in his height and he's not growing as his peers. And his friends have facial hair. There is change in voice in his peers, but I don't see in him. And even he says the same thing, and he's worried.
Okay, okay. I can see your concerns regarding Joseph's issues also. So, can you remember anything, Rose? What exactly happened at 9 years? Was it something that happened, some trigger, some surgery, something that was there just previously that happened, or it was a gradual process that you started observing that he's not growing well?
It was a gradual. I feel your voice is far. Can you are using phone or
I'm
something?
on the laptop. I'm the laptop.
Okay.
Now it's fine.
Yeah, now it's fine. Go ahead.
I've taken the laptop.
Please take care of mics. Okay.
Okay, okay, fine. Okay, so it's been a gradual process, fine. And have you, what has been done for this up till now? Since 9 years you've observed this, and now Joseph is 16.
Yeah, we visited our GP several times. He told us that this is normal. He said you can observe him. He told us in the beginning, let's do the growth chart every year to see how much height he's picking.
Okay.
So we did the growth chart. He was picking up to 5 centimeters per year.
Okay.
So the GP was telling, so no need to worry. Let's see, it will be fine with time. This is what he told. So we were just because now he's 16 years. And I feel the time too much time we passed. Now I am worried. That's why he referred me to you.
Okay, okay. So I would just ask you a few questions related to this issues only. In the family itself, you and Joseph's father, are you all related to each other, or are you all cousins by any chance, or
No, we are not related to each other.
Okay. And how many children do you all have?
We have 3 children, and Joseph is the elder one.
Okay. And so you and Joseph's father, had any one of you all had this issue of being short? When you all were...
Yes, doctor. His father said his maturity was late.
Okay. And was he also short when he was young?
Yes, he said that he was short. Then he picked up the growth.
Yeah.
Like this, I'm not much sure about the years, the age. I'm not sure.
And presently his height is fine, you feel?
Yeah, presently he's in 50th centile.
Okay, okay. And anybody else besides Joseph's father having this issues of having a short, being short?
No, doctor, I don't know.
Okay, okay. I would just ask you a few questions related to that. Does Joseph presently have any problems in his breathing, or he has shortness of breath, cough, any other issues?
No.
Does he have difficulty having pain in his chest or having his heart racing very fast?
No, doctor.
Okay. Does he have any fits or any problem in his vision?
You said fits?
Fits, right?
No fits.
No fits, no problem in his vision also.
No.
Any throwing up, any loose motions that he has, or constipation,
No constipation, no throwing up.
any pain in the tummy,
No tummy pain, doctor.
any problem in the peeing, that is the urine, being
No.
less or having blood in urine or anything?
No.
No. Any excessive weight gain all of a sudden you feel he had?
No weight gain.
No weight gain. Okay. Any rash over the skin that he has, or any allergies he has?
No rashes or allergies.
Any muscle pains, any bone problems?
No.
Okay. Any previous illness that he has besides this that you're talking to me?
Actually, no, doctor. He was growing well till the age of 9 years. And then I feel that sudden there is no good growth in his height.
Okay. So basically, no previous admissions, no operations, any surgery?
No previous admissions or no operations.
Okay. What investigations have been done? I know about this, some blood tests. Do you know anything else?
No, doctor. The GP did the same thing.
Okay. Has he been started on any medicine, Joseph?
No, he's not on any medicine. He said, just go, I will refer you. And if you get, they may start you on anything. But till now, he's not on any medication.
Okay. Any team of doctors besides the GP who has seen him?
No, doctor. As I told you, he was under observation only.
Okay. I appreciate that. Just a few personal questions which we generally ask, and you're absolute. If you feel uncomfortable answering any of them, it's your choice, Mrs. Rose. Joseph, and even you can participate, in fact, in the discussion. And in this part, I would really appreciate your participation. So, Joseph, what do you feel? How has this emotionally affected you, this problem?
Actually, doctor, I have problem in school. My friends say that I am short and I'm not like them. There's something going on, and because of that, I am not interested to go to the school, and even my school performance is reduced. So I am worried.
Okay, I'm really sorry to hear about this, Joseph, and we are here to help you and support you, right?
Okay.
Well, the school academics, since when do you feel has it been affected?
Since the age of 12 years.
Okay. And how do you find is your home environment? Do you feel it's...
No, home environment is fine. I have no problem with the home environment.
Okay. Like there are many people who try drugs, alcohol, cigarettes, smoking. So have ever you tried all this, Joseph?
No, doctor.
Okay. And do you have a partner or someone special in life?
No.
Okay. And do you have any time had this kind of a thought that I hope I would not be there, or my existence wouldn't have been there? This kind of a thought?
No such thoughts, but I am not interested to go to school now.
Okay.
9 minutes, 4 minutes.
Fine. Mrs. Rose, I would just 5 minutes, huh? Mrs. Rose, 9:05. Mrs. Rose, could you please tell me more about the family? You and Joseph's father stay together?
Yes, doctor, we are together.
Okay, and what any financial issues or at home?
No financial problems at home.
Is this affecting your family and the other siblings emotionally?
Yes, doctor. Actually, I see some changes in the behavior. He is angry sometimes, and he don't want to play with his siblings like how he was playing before. and
Mm-hmm.
he doesn't show interest in his school studies.
Yeah, yeah,
And
yeah,
also
yeah.
I feel that he's lazy, uh, like this. He's not happy going like how he was before 9 years
Completely.
of age. So I
Okay.
see some disappointment in his behavior.
Okay, but over at home, his activity is good, or he's lethargic and every time.
No, no, he's not every time lethargy, but he doesn't want to play like how he was playing before. He's
Okay.
not interested
Do
to go to school.
Oh, okay. I'm
Okay.
really sorry to hear about that. And do the other siblings feel that they are neglected because we're taking care of Joseph's health?
No, doctor, I am
Hmm.
taking care of them as well. No, they are not feeling like that.
Okay, about the puberty, I would just like to ask Joseph that uh, uh, do you like still he's not got the hair on his body, right?
Yes, no facial hair, and also no change in voice.
Okay, Joseph, if you feel comfortable, it's fine. You can are your private parts, or can you feel it's more in size, increased, or anything like that? Do you feel if you're comfortable, you can answer. If it's not, it's
No,
absolutely
no, doctor, no.
okay. Fine. During birth, Mrs. Rose, do you feel that any problem when he was when you were pregnant, like fever, rash, or anything?
No, no problem.
Any medication that you had to take, or any
No,
investigations? That
no, doctor.
nothing.
Was
What
on.
was the birth weight of Joseph?
Actually, when he was born, he was little weight lower side. His weight
Hmm.
was 2.4 kg, but
Okay.
he picked up. He picked up, and his growth till 20, till the age of 9 years was on good. He was on
Okay.
a 10th centile before, ninth
Mhm.
centile for height, and for weight he was on 25th centile.
Okay. Okay. I understand. Did he require any NICU stay or anything after that, after he was born?
No.
Are all his shots completed? Immunizations have been done,
Yes, yes.
even the special ones?
Yes, doctor, all are completed.
Any delay that you have found when his development means when he was his walking, his talking? Has
No,
all this been on time?
his
Or you feel
walking
he's
and talking were fine. Only now I feel that he's short. That's it. Otherwise, everything is fine.
regarding his diet? Could you tell me any special diet is advised to him, or he how?
No, doctor, his weight is fine. He's not overweight.
Hmm.
Doctor, diet, we had the dietitian says he can take the regular diet. He doesn't
Oh,
take any diet restrictions.
okay, okay. Um, well, is there anything important, Mrs. Rose and Joseph, both of you feel that I should know and I haven't asked that?
No, doctor, I think you asked everything.
Okay, okay. Uh, um,
Let me see how much time.
I okay.
49 seconds left. Okay.
No, I'll not leave that. I'll utilize it somewhere. Well, but did his father also have the same issues emotionally? Did he ever specify to you,
No, when the
Mrs. Rose?
father, though he was delayed in getting the puberty, he was a happy child. He said.
The
Mm,
other two sibling, yeah, yeah. Go ahead, Doctor.
he
Sorry,
was
Mrs.
fine.
Rose.
The father was fine.
And the other two siblings, what about their height and their age?
The other two, after the Joseph's delivery, long time I did not had children. So the other two
Okay.
are very small. One is 6 years and another
Okay.
is 8 years.
Okay. I have taken the history of 16 years old Joseph from him and Mrs. Rose, who presently have chief complaints of short stature as well as delayed puberty, which they have observed since the age of 9 years, with the father having a similar complaint with no other systemic involvement, no symptoms, or no signs having any other systemic involvement, with Joseph having an emotional impact as well as a social impact, where he at school is facing bullying depression, anxiety, as well as a poor academic performance and his denial to going to school. This in turn has impacted his family emotionally, with a positive history of having only a low birth weight at the birth. Yes, with no other chronic illness in the past. So my
Okay.
most probable diagnosis for this could be a constitutional short stature, a familial short stature. I would like to rule out a few illnesses like a celiac disease or a growth hormone deficiency. They'll be quite down the line, and along with a psychological counseling for Joseph, support for Joseph.
Okay. Did you ask any questions related to celiac disease in your
Yeah, I asked diarrhea, constipation, skin rash. I mean, so, diarrhea,
Only
weight
this?
loss.
Okay. What do you think? The celiac disease can present silently at this age, from the age of 9 years? Do you think?
Celiac can come up at any age. The person may not have celiac initially, but can have celiac later too.
Okay. But there was no.
But there is a very strong family that's very down the lines. However, my first initial and probable will be constitutional short stature and delay on growth and puberty.
Okay,
And
still
familial.
some important diagnosis is being missed. Can you just think over?
Growth hormone deficiency should be
Growth
thought of.
hormone deficiency also can start from 9 years.
No, it will be generally by the age of 4 to 5 years.
So still top than this, you should have some important DDs.
Other chronic, they could be chronic illnesses. Are most of them are ruled out. The renal ones, the
No
thyroid will also come up very early. Thyroid will also, hypothyroidism will come up quite early, not so late.
Okay,
And
we'll discuss it later. Now you said differential diagnosis. Now tell me what investigations you want to do, provided here only CBC and renal functions are done and it's normal.
Okay. I will, after the complete blood count and renal function test, even a baseline liver function test, a urine analysis, a stool routine that needs to be done, a celiac, for the celiac test, anti-TTG and IgA levels needs to be done. The bone X-ray, the wrist X-ray of the left hand needs to be done in order to know the bone age. Growth hormone stimulation test needs to be done to be, if at all these causes are not in the line, growth hormone stimulation tests needs to be done. We can do a thyroid function test, but that is very coming at 9 years is a bit unlikely. And yeah, so these
Okay,
are the.
you said bone X-ray, growth hormone stimulation test, thyroid function test.
Yeah, yeah.
Apart from that, anything you want to do?
This is Joseph. It's a boy, so I will not do karyotyping.
Okay, so okay.
I can do karyotyping just to know whether he is a mosaic turner. That will be kept very rare. Although no deformity, the mother told me. Nothing but a mosaic maybe.
Common bone X-ray, growth hormone. Apart from that, anything else you want to do? So okay, if this is
okay, besides this, people are prompting under this LHF and FSH. People are prompting on the chat.
Please don't write on the chat. I will mute the chat now. I don't want to see any this here now. Okay, so
LH and FSH to see for any delayed.
What do you see in bone X-ray? If this is constitutional delay, what will you see?
In constitutional short stature, the constitutional age will be more than the bone age, which will be equal to the height age.
That means bone age is delayed. Okay. Yeah. So about the LHS and FSH, what will be your interpretation if this is constitutional delay?
This will be low.
Okay, low. So if this is constitutional delay, how do you want to treat this patient?
Well, I will involve the multidisciplinary team for this. First, initially, I would like to counsel on my basis itself that itself will take time and he can outgrow, and this will be fine on its own. So counseling is very important, especially he is facing a lot of issues at school also. So counseling with a therapist is important. If still the parents are very anxious and it's having a severe impact on his health, then the endocrinologist can be involved, where injections, testosterone can be given to him.
Okay, how the testosterone will help him?
That will basically help him in order to get his pubertal spurt.
Okay.
So that, and so the multidisciplinary team, he may even require a psychiatrist. He has to be referred to CAMS because he's severely depressed as per his mother also. So childhood, adolescent, and mental health services needs to be informed regarding the same. And yes, yeah.
So you said psychologist, endocrinologist, CAMHAMS.
Psychiatrist if required. If requires medication, psychiatrist and CAMS, childhood, adolescent, and mental health services. If required, a social, but no, there's no rule of social.
Okay. Any important red flags you missed in your history?
He was normal, hence I did not ask whether, as per that, is disproportionate or stature seems to be proportionate, and I asked about all the endocrinological or the organic causes. And
okay, did you ask about okay, now we will go for discussion. I think that's all. You will mainly hear the multidisciplinary team. Education is important. Counseling. We use the word reassurance is important here.
Okay. I said that in beginning like counsel. Okay, reassurance.
Yeah, reassurance is the right word instead of counseling, because you will reassure that he will gain the height. And counseling, educating about the condition. Even you can say that you can give some leaflets to read about it. That it runs in families. His father had the same problem. And endocrinologist you want to approach. Do you give testosterone to all children with constitutional delay?
No, not with all children, but this is having such a significant impact. Psychologically, it's having such a significant impact to him. So this is one of the indications, as I remember.
Yes, there is significant impact on the psychology, that he's not growing as his peers and there is bullying. Yes, for the beginning of the pubertal spurt or for the secondary sexual characters, we can give the testosterone. Okay, so let's go to discuss from before.
Okay.
You missed some important red flags which has to be explored in systemic review. You asked about constipation. I told that he's lazy and lethargy. At that time, you asked like he's lazy always or only during this time. 1 minute. I told no, not always. But still ask about intolerance to cold, intolerance to heat, to rule out hypothyroidism.
Hypothyroidism. Okay.
Thyroidism. Here write all the causes of short stature in the side, and you have to ask the history based on it. For hypothyroidism, you are for constipation. I don't know. You asked for celiac or
yes,
for...
I know. I asked constipation for both. I had endo. I had written, so in that I had put constipation, and that was for both actually that I asked. Okay, but I forgot about neck swelling. I wanted to ask neck swelling, and I forgot about that.
Yeah, neck swelling and even intolerance to cold. It will be, if anyone asks, constipation can be a common question for anything. If anyone asks intolerance to cold, it will be a clue for the examiner that you are asking for thyroid. So you should show something that you are asking there for the thyroid. Okay. This was not asked. And one more important, in the CNS, you asked for fits, you asked for vision, but you did not ask for headache.
Okay. Yeah.
Why
Headache.
headache is important?
Because even sure this tumors that can be there, which can lead to pituitary deficiency and growth hormone deficiencies, can lead to, yeah, headache.
Yeah, you did not ask about headache, early morning vomiting, and also,
Vomiting I asked, but not early morning. Yeah.
yeah, a headache. When you ask about headache, it has to be connected. Early morning vomiting.
Oh,
And when I told that the behavioral also, you did not ask in the systemic review. It was asked
I
in
asked in the
the social.
social. Yeah.
Yeah,
Okay.
it was asked in the social.
Hmm.
Because behavior, abnormal movements, headache, and early morning vomiting.
Oh,
All this is very important. Fits you ask, that is the abnormal movements, it's considered, but you did not ask headache and early morning vomiting, and behavior also asked in the systemic review. Okay.
okay. Oh,
Puberty, skin, behavior, joints, all these things. You asked about muscles and joints, that's okay. Behavior was missed in systemic review, but later it was asked, so it covered up. Skin, along with rashes, what else becomes important in skin?
even the dryness in the skin and dermatitis in the skin and then
I think we should
hypopigmentation.
not just limit to rashes. We should also ask any birthmarks like
Hmm.
this.
Okay. Okay. Any
Because,
rashes or any marks? That is the way I should. Okay.
yeah, rashes, marks, or any, even you
Okay.
can ask as birthmarks. Why
Okay.
birthmarks? You, which can,
Neurofibromatosis.
yes,
That can lead.
yeah. These things were missing in your systemic review. Otherwise, it's okay.
Okay.
The important in your differential diagnosis is the tumor. Which you missed, even though you have to, even though it may not be by the history, but you have to put it in the last. You should not miss this. One of the red flags here in this child is the behavioral change. Some children can just present even with only behavioral change. What do you think?
But then, what will it not be lethal putting tumor
Don't put it on
the
the top.
differential?
Yeah.
The examiner will say that.
No, no, no. Don't put it on the top. Put it in the bottom. Like constitutional delay in growth will be your first. Then even familial,
Familial.
you will be your second. First and second, constitutional and familial. Then go for hypothyroidism. Then go for tumor.
More than
Celiac.
hypothyroidism, Dr. Noor, I would feel celiac would be better, which is a very silent disease.
Okay, but hypothyroidism also, you said that it will not present. No, even the
Acquired hypothyroidism
yeah,
can present later.
secondary hypothyroidism.
Acquired, not sick. Acquired.
Okay, what acquired can come late. It's not that it is not there. Don't leave hypothyroidism. It is one of the
Okay.
important DDs in this case. And
Because of
also,
academic delay and all that.
yeah, you can mention tumor, and at the same time, if you are afraid, you can tell that there is no, because this, when this history came before in the exam, it was expected to tell tumor as the differential diagnosis
Okay.
also.
Okay, so I'll say tumor, but although most of the red flags have been out, but still because of the behavioral
But
changes,
here you
tumor is
did not ask about headache. A headache also will be there. So if we don't ask, it will be a problem. So
okay.
headache, behavioral changes, early
Okay.
morning vomiting, all
Okay.
these things will contribute, even
Okay.
abnormal movements. Okay. So there is some
Okay.
behavioral change in him. Okay, at the
Mhm.
school bullying, but even at the home, he's not interested to play with siblings. He has angry character, disappointment maybe because of bullying, but there is some behavioral like anger, not playing
Mhm.
with siblings, not showing interest in school.
I thought all his friends are bullying him. That's why he's removing the anger at home.
Yeah, it's okay, but still you cannot.
But still, there is a possibility
What
there.
is the constitutional growth of delay? It's a diagnosis of exclusion or not?
Exclusion. Yeah.
Yeah, then if you suspect anything, you have to exclude it.
Hmm.
So he may need, even if you don't want to go for imaging by yourself, you will involve your consultant, you will involve the neurologist, whatever, for the evaluation.
Okay.
Okay. So yes, in your examination, don't say thyroid function tests as last. Again, thyroid function test is very important. Okay. Thyroid function test, bone X-ray. And for growth hormone deficiency, will it present so late? It should be early, right?
Actually, 4 to 5 years they present generally. Yeah, that's why I put
this one was started at 9 years.
9 years. Yeah.
Yeah, and also they can fall in their centiles. The constitutional delay, they can fall in their centiles also, but it should not be too much fall compared to the mid-parental height. It should be within the 2 centiles from the mid-parental height, right?
Yeah.
Yes or no?
Yeah, right.
They can fall in centiles, but it should be less than 2 centiles from their mid-parental height. And again, later they will catch up. Okay, this is my comments. Otherwise, I think you covered everything. You covered history of present illness, medications you asked, allergies you asked, nutrition also was asked, height and weight was given to you in the
Pain is in 16-year-old. We should not even miss out the heads. So heads, I covered heads and then I went into birth immunization.
Yeah, so your birth history was asked, and low birth weight. This was just a presentation, but he catched up later. Development was asked, vaccination, okay, past medical history, nothing significant in this patient. It was asked, and family history was asked about the father is delayed, and school performance, smoking, alcohol was asked, bullying. Okay, I think it was fine. Anyone catched anything which was missed can give us. And also if you want to tell anything about constitutional delay of growth which we missed, can go ahead.
Hello.
Please open. I have muted all. Please open your mic.
Okay. No. I just was telling, and the differential diagnosis, it is one item is there for the CNS involvement like septo-optic dysplasia. That can cause the visual defect and pituitary abnormalities and hypoglycemia. So that it may not be applicable here, but that is a differential diagnosis.
For short stature, you mean?
Yeah, short stature.
But it all will be present. It will all present from the early age.
That may be. That might be.
Yeah, can you repeat the presentation of septo-optic dysplasia?
Septo-optic dysplasia actually present with some midline defects, pituitary abnormalities, growth hormone deficiency, visual defect, hypoglycemia.
Okay, and I want to tell all, this is my personal feeling. If when we tell the investigations, always tell the diagnose in any case, the diagnostic and the most important first, then you say the supporting investigations. Okay, like here Dr. Muzna started with LFT. She told urine analysis, stool, what you said, stool analysis, celiac disease. All these things will not come here on the top. Tell the bone X-ray first. Okay, bone X-ray and thyroid function tests. These are all to come to your diagnosis. Other things will support your diagnosis only, like CBC, LFT, RFT, maybe for the chronic problem, children with chronic issues. Okay, and here LH and FSH becomes more important. So bone X-ray, LH, FSH, TFT, this is because you want to come to a conclusion that he is constitutional delay. Then based on your suspicion, because again, this is the diagnosis of exclusion. If you suspect anything, other investigations, if you suspect tumor, maybe you have to go for MRI also in imaging. And also if you suspect other things like celiac or anything based on your history or some rashes, you can go for the screen. But still, if you want to tell, you can tell it, but keep it. Tell the most important investigations for this case will be the bone X-ray of the left wrist, then LH, FSH, and thyroid function tests. Other things and all you can tell down. Any comments for this?
Dr. Noor, just I want to ask for this long history. Also, we put the tumor as a differential.
Yes.
Okay.
There are some behavioral changes. You have to explore still. You have to explore. So you can refer this patient. Behavioral changes can be just even due to the bullying and other things. But still in the history, headache was not asked, then how you will tell? And other things also. So just keep it as in the down: hypothyroidism, tumor, even celiac disease, growth hormone deficiency, maybe in the last, but don't tell as the first because it will present early, not at this age. Okay.
Okay, thank you.
Hi, Dr. Noor. Just I want to ask if here, because for me in the systemic review, I used to ask for genetic. Usually, I'm asking just if you feel the patient has an unusual feature or he's not looked like other brother or sister.
Yeah, you
So
can
I guess
ask.
here.
That's a good point. Yeah, because to rule out any syndromic problems.
And I don't know if from the letter from the GB, he mentioned that he didn't do any investigation for the patient, because otherwise we have to ask if he did bone aid before or he did any hormonal investigation.
No, he did not do anything. There were apart from
GP had done
mentioned.
CBC and LFT. That was written only CBC, LFT done, right?
CBT and
Yeah, and he mentioned in the letter. Okay, and we asked about development, right?
yeah, development. She asked. She asked about development.
For me,
Yeah,
it was a good history, really. And
yeah,
she mentioned most of the points
yeah.
in a good time.
Yeah, Dr. Muzna, I want to ask you, you told what apart from this LFT urine analysis, something else you told.
I said this now from TTG, IG and IgA levels. Then you told LHFSH and bone.
For
bone
stool,
nucleus, and I even said chromosome.
stool you said something, what? For stool?
Stool routine only I had said.
Okay, no problem, stool routine. Okay, I want to ask you, if this was a girl, what investigations you will add?
Chromosome.
Yeah.
Variotype. Even this we can actually add, I said, well, very rare, but can be a Turner mosaic, like half cell lines are XY and the remaining half are XO, but very rare that is. So I'm not going to put my foot into the grave.
Even blood sugar is also important. Blood sugar.
Yeah. Renal function test has blood sugar, right? No.
No.
Okay, fine. But they do should.
And, oh, yeah, you you missed some important things. Now I remembered. In the bedside examination, did you tell BP?
No, I didn't say BP.
Yeah, blood pressure is important. Fundoscopy is also important. Okay. See, always rule out the most, disastrous.
Life-threatening thing.
Yeah, life-threatening or disastrous things before coming to that, which is a normal diagnosis. Most of the diagnoses which are normal will be the diagnosis of exclusion. So BP fundoscopy is important in this patient. Okay. And always start your management with, you will again view the
this
patient.
I should have said, I should have brought the channel.
Your 14 minutes history is enough. Detailed history it is. No need to tell that you will take the history again. You will tell that you will examine the patient completely and do the vitals. So here, when you are telling the vitals, you will signify of blood pressure, and bedside you want to do fundoscopy. And even if you want to add blood sugar, you can add, no problem. But BP and fundoscopy is more important in this case.
I think urine dipstick as well for proteinuria. I don't know whether it's a point of care test. Point of care is the blood sugar.
So tell all these things and then come to your final
investigation.
assurance after when you are asked that if this is constitutional delay, what's your, I think your answer was correct. Reassurance and testosterone, especially in this case, has to be considered because he has bullying and there's some disappointment, depression, like this. Okay, psychologist.
How old is this child? 16 years old?
Yes.
So 16 years old, no any feature of puberty. We cannot say this is delay puberty with short stature also.
Yes, this is delayed puberty only. Okay, well, anyone know what is the definition of constitutional delay of growth and puberty? CDGP.
It's different in boys and girls. In boys, absolutely no testicular, means that that is by the age of 14. It's by the orchidometer they see whether the testicular volume has increased. That's why I asked this question to him, whether his this is the first sign of puberty in boys. The first in girls will be
Boys, the first sign of
tilak by 13. 13 and 14, tilak and what is this? Testicular enlargement.
So do we know the definition? Anyone knows the definition?
This is the definition. Delayed.
No, the age.
Age is saying the 13, by the age of 13, a female not getting tilak, and by the age of 14, the boy not getting testicular enlargement.
Okay.
لقيت؟ لا 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 العلبة ما لقيتها. العلبة يا رنا.
All.
The clue in the history that the patient has increased in his height by 4 centimeters or 5 centimeters per year, right?
Yes.
So usually institution short stature, they have increasing in the height, but slowly, not like other peers, but they're increasing. This is the difference between them and the chronic disease and the other problem.
Yeah, they will increase, but what happens during puberty is there is sudden increase in the growth spurt because of this.
For normal patient.
In normal, what happens when the 9 years or 10 years, what is the range? She said 9 to 14 for boys, 8 to 13 for girls, right?
Yes.
During this age, what happens if someone starts the puberty, there will be sudden increase in growth spurt by these hormones because of this luteinizing hormone and FSH.
Yes.
Release.
So in constitutional, they are still increasing, but they cross the centile because they are increasing slowly.
Yeah. This is the commonest cause of delayed puberty. It presents to pediatrician most frequently in boys, but the incidence of boys and girls is probably similar. On the growth chart, slowed height velocity is seen just before puberty, and this is normal. You can see falling in the centiles also just before puberty, which leads to height crossing the centiles downwards. So even if there is any growth chart or if they show the growth chart, you can catch from that. As the puberty begins from 9 years, before 9 years before 9 years, you can see that there can be fall in the growth of height velocity. And also that means in our patient, I said he was before in 25th centile or something. He fall, but it should not cross more than 2 centiles the mid-parental height. Okay, it means it should not fall too much. It should not cross 2 centiles when you compare to the mid-parental height. This becomes obvious at the age when most children are in their mid-pubertal growth spurt, which leads to an increasing gap in height between the patient and their classmates. So the other children will be in mid-pubertal growth spurt and this child will not have this. This will cause an increased gap in height between patient and their classmates. It is commonly associated with family history of pubertal delay. Ask mother at what age she started to menstruate. Ask father whether he had his growth spurt around the same time as his peers. So other way you can ask that, she asked this question, whether father had delay in puberty. The investigations may show, someone's mic is open. So this is very important. Investigations may show prepubertal levels of LH and FSH and a delayed bone age. That means during the age times of puberty, they should have increased this in this LH and FSH. In these patients, you will see the prepubertal level and also there will be delayed bone age. So these becomes more important investigations here. Okay, the bone age and the FSH and LH. This normal growth pattern can be difficult to distinguish from pathological causes of poor growth. It is therefore important to make sure that there is not chronic disease process. So these are all you have to rule out in your systemic review. Any chronic disease, syndrome, so or endocrine cause. So for this, you can ask any unusual features also, as Dr. suggested. So chronic disease process, syndrome or endocrine cause, that is pituitary thyroid disease or Cushing's syndrome, contributing to persistently poor growth and failure to enter puberty. In girls, Turner syndrome needs to be specifically excluded by carrying out a karyotype. Any short girl, even there are no features of facial features or other features of Turner syndrome, still you have to rule out Turner syndrome in any short girl. So this was our case. Let's read about hypothyroidism. This typically causes gradual slowing of height velocity, height crossing down the centiles over a period of months to years, while the weight continues to follow or increase across centiles. This will result in increased BMI and relatively short overweight child. After initiating treatment, the height will increase rapidly and BMI should fall. Did not give much. So we should know this is very important, bone age. This involves left wrist X-ray, okay, which is interpreted based on which growth plates have fused. So you should know the causes of delayed bone age and advanced bone age. So delayed bone age, one you see here, constitutional delay of growth and puberty. This is important. Turner syndrome can also have any chronic disease, children with chronic disease, growth hormone deficiency, poor nutrition. This is malnutrition, not taking enough food. Decreased androgens or estrogens, that is delayed puberty. Emotional deprivation can also cause, and increased cortisol levels can cause delayed bone age. That's why you see even in Cushing's syndrome, delayed bone age. So again, this is very important. You have to remember constitutional delay, Turner syndrome, chronic disease, growth hormone deficiency, poor nutrition, decreased androgens and estrogens, emotional deprivation, increased cortisol. So for advanced bone age, opposite to this, here decreased, here increased. Increased androgens and estrogens, precocious puberty, hyperthyroidism, cerebral gigantism, Sotos syndrome, Weaver syndrome. More than all these things, remember this increased androgens and estrogens, that is in precocious puberty, and hyperthyroidism, okay, and cerebral gigantism, that is the Sotos syndrome. If you can remember this, it's okay. Otherwise, it's okay, fine. Okay, now we will take the break for prayer and then we will be back. So this is from patient info. Normal puberty occurs across an age range, and diagnosis of pathology requires familiarity with normal range. Okay. See separate article, normal and abnormal puberty, for more details. Delayed puberty, we should know the definition. Maybe they can ask you. So delayed puberty in boys, the absence of testicular development or testicular volume lower than 4 ml by the age of 14 years. In girls, the absence of breast development by the age of 13 years, or primary amenorrhea with normal breast development by the age of 15 years. That means boys, it's clear. By the age of 14 years, they don't see any testicular development. Testicular development is, if it is more than 4 ml, then the puberty is started. So usually testicular volume lower than 4 ml by the age of 14 years is delayed puberty. And in girls, the absence of breast development by the age of 13 years, or they have breast development, but there is no menstruation, that is primary amenorrhea by the age of 15 years. Okay, this definition we all should know. Most boys and most girls with delayed puberty have simple constitutional delay in growth and puberty, that is CDGP, constitutional delay in growth and puberty, and do not need detailed investigations. Rest all no need to read, we will read ourselves. We'll just go to the diagnosis and management. Okay. So this is what they will ask in the exam, most important things. So in the history, because we did history today, we should know some of the things which we should extract. Growth pattern. Adolescents with CDGP have long-standing history of short stature. Use an available growth chart. Use any. So they will have long-standing, like in our case from 9 years, now the patient is 16 years old. So long history of short stature. General health, any symptoms of chronic health has to be excluded, chronic ill health. Gonadal impairment, history of cryptorchidism, orchidopexy, or gonadal irradiation. So we can ask any problems before, which was asked past medical history. Then sense of smell, that is Kalman's syndrome. Keep this in mind, this was not asked. Okay. Family patterns, age at menarche in female members of the family, and delayed growth spurt. Social and educational aspects, any indications of psychosocial problems, that was asked. So in examination, you will concentrate on height, weight, any suspicion of malnutrition, measured parental and sibling heights, pubertal staging, dysmorphic features. So in the history, you can ask as any unusual features in the face, you can ask, no problem. Full general examination, including fundoscopy, visual fields for the pituitary tumor, and any indication of chronic disease, that is finger clubbing. So when you are telling, you will tell that you will do the full complete examination of the child, including the fundoscopy. And visual fields also is important when you are suspecting, to rule out the pituitary tumor, and any indications of chronic disease like clubbing, pallor, like this. There is someone's mic on. Okay, so remember, in the general examination, when you're doing, you will be concentrating on the chronic diseases. So pallor, clubbing, and all those things. And also for the pituitary tumors, better to see for the fundoscopy, and also offer for the visual fields. You can tell in order to complete, or you will refer the patient even for the ophthalmology, no problem. Investigations, this is important here. Most girls and boys with delayed puberty have constitutional delay in growth and puberty and do not need detailed investigations. So in selected cases, what do you do? Investigations for chronic disease, CBC, ferritin, renal function tests, electrolytes, celiac screening, urine analysis for blood and protein. So all, I think most of the things we covered when we are discussing. This was in our case, FBC and kidney function test was done by the GP, but we have to do other things like ferritin also. Celiac screening was told, and urine analysis for blood and protein. I think this is for to rule out nephrotic syndrome and also the nephritic features. Okay. Then investigations related to disorders of gonadal axis, that is chromosomes, Turner syndrome and Klinefelter syndrome. So he's telling for delayed puberty, but in short stature, the Klinefelters will not come. So for us, chromosomes mainly for Turner syndrome if the patient is a girl. Okay. Basal, FSH and LH, and follicular stimulating hormone and luteinizing hormone investigation has to be done here, and serum estradiol and testosterone. Basal levels of LHS and FSH are low in CDGP or hypogonadotropic hypogonadism, usually elevated in those with gonadal failure. Means if there is, like in Turner syndrome, if there is streaky ovary, okay, whenever there is gonadal failure, there is a chance that there is increase in the LH and FSH. Otherwise, in CDGP, it will be low, and also in the hypogonadotropic hypogonadism. Prolactin and insulin like growth factors as a screen for growth hormone deficiency, and thyroid function tests. So very important. So for on the top in this case, put this, if this is a girl, you can put chromosome also, and FSH and LH is very important because it will be low in the constitutional delay. And for growth hormone deficiency, you can ask for prolactin and insulin, insulin like growth factors and thyroid function tests. Okay. I think prolactin is not for growth hormone, this insulin like growth factor. Why they are doing prolactin? Anyone can tell me? Hello?
I guess high prolactin suppress LH and FSH.
Okay, maybe. But this
even for panhypopituitarism, I think you need all the hormones to know the levels.
Okay, but this insulin like growth factor 1, it is a screening for growth hormone deficiency. It's a screening test. Okay. Then thyroid function tests is very important. Don't forget, even though there are no features, you have to rule out you have to do TFT. Then gonadotropin releasing hormone test and growth hormone test can be done, but it again depends upon your patient and your evaluation, all these tests. Some cases of central delay are difficult to assess, and the GnRH gonadotropin releasing hormone stimulation test cannot distinguish between physiological delay and gonadotropin deficiency. So GnRH test and growth hormone can also be done. Okay. Because they are telling just by gonadotropin releasing hormone stimulation test, they cannot distinguish. Next is the pelvic ultrasound in girls. This will be usually in the, if you are suspecting Turner's syndrome. So pelvic ultrasound, bone age, a delayed bone age may occur in CDGP, growth hormone deficiency, and also in hypothyroidism. Bone age is established by a wrist X-ray, but it is mentioned particularly left in mark. MRI and CT scan of the pituitary and surrounding structures may be indicated. So put it in the last, as you put the tumor diagnosis in the last. Then management, CDGP, medical treatment is often not necessary. Reassurance and monitoring may be sufficient. However, short course of sex hormones may be used to allow individuals to catch up with their peers and to prevent psychological and emotional sequelae. So your main aim is to give the sex hormones. In boys, it will be testosterone to help them to catch up with their peers and to prevent psychological and emotional sequelae. Otherwise, your main, this is just reassurance. Okay. So in boys and in girls, they have given separately. In boys, induction of puberty may be achieved with short course of low dose testosterone therapy for appropriately selected boys with delayed puberty. You will not offer for all, only for the selected boys, especially who are affected with the psychological and emotional problems. So short course of low dose testosterone therapy. Testosterone is given by mouth as a capsule or injection. Treatment is given for 3 to 6 months and then situation is reassessed. Response is usually rapid and effective. There is not yet sufficient evidence for routine use of other therapies like growth hormone and aromatase or anabolic steroids for CDGP. So the only thing we will tell in the exam is the use of low dose testosterone. That's it. Okay. They may not ask you the how they give and all those things is not needed. Just remember low dose testosterone as capsules or injection. And the time they give is 3 to 6 months and reassessed, and response is usually good. This much is enough. Other things is not indicated like growth hormone and anabolic steroids or aromatase inhibitors. Then CDGP in girls, gradually increasing the doses of estrogen treatment. So boys testosterone, in girls we use estrogen treatment with gradually increasing doses with cyclical progesterone therapy once adequate estrogen levels have been achieved. So gradually increasing doses of estrogen with cyclical progesterone therapy is given once estrogen levels are achieved. This is to bring about the regular, I think, menstrual cycle. That's why they are giving estrogen, then cyclical progesterone, because they need to withdraw the hormones for the menstruation. Then chronic disease, if there is any, treat the underlying cause if possible. Induction of puberty and hormone treatment may be required. So for primary testicular failure, what do they do? Like, for example, in primary gonadal failure, like in Turner syndrome, girls, what they do? Estrogen replacement should be gradual to avoid premature fusion of epiphysis and prevent overdevelopment of areolae of breast. So gradual estrogen is given in girls. Induction of puberty usually starts around the age of 10. Gradually increased doses of oral ethinyl estradiol or transestradiol are used with cyclical progesterone therapy once adequate estrogen levels have been achieved or if breakthrough bleeding occurs. If growth hormone is also needed, estrogen therapy is usually delayed under the age of 12. So growth hormone is also given in cases of Turner syndrome. It is one of the indication. Okay. Transdermal estradiol and low dose of combined oral contraceptive pills can be used. All these things for us at the moment not needed. And let's see in the boys, what do they do? Boys, for the primary gonadal failure, regular testosterone injections are preferred, but oral testosterone or testosterone patches, gels, buccal pellets are the alternatives.
So in Turner, we are giving estrogen plus growth hormone both, right?
Who? Yeah, I think not estrogen, they will start after at the age of 10 years later. Before they will give growth hormone. What he is telling, if growth hormone is also needed, estrogen therapy is usually delayed until the age of 12. Estrogen is just to bring the secondary sexual characters in them, and also this is the thing, because they will have primary gonadal failure, right? So they cannot help them with this to bring about the menstrual and to make them the female characters. This is the main trait. And the growth hormone is to increase their height. So usually, and there is opposite action here. The estrogen will accelerate the fusion of the bones. That means epiphysis, I mean, premature fusion of epiphysis. Estrogen can cause. That's why if you are giving growth hormone, it will be delayed until the age of 12. This is what he's telling, for the increase of height. Okay. I hope it's clear. So this is what in for constitutional delay, the important investigations will be bone age and the FSH and LH, and your interpretation is it will be low. Okay, and if you have ruled out other causes like the patient has no chronic disease and other things, you can just reassure education. Okay, education, psychological support, social support, and behavioral therapy also can be given in patients with behavioral problems. Okay, and referral to endocrinologist for the testosterone also, means they may need the treatment of low dose testosterone.
He mentioned Klinefelter syndrome here. So they also have constitutional delay.
No, no,
But they
no.
have
Klinefelter syndrome, he has mentioned this is for delayed puberty. But I don't think they have a short stature. This is just.
no, they are tall actually. But
Yeah.
I was thinking maybe the final height is high, but I don't know how they are developing.
I think here the topic here is not mainly constitutional delay. The heading here is delayed puberty. So I think he has given for that. This is what I think. I'm not sure that they will have short stature.
Yeah, they have gonadal atrophy. Maybe because of that.
Yeah, and they have low testosterone, right? So their puberty will be delayed. So they are one of the candidates for the testosterone replacement.
Yes.
And also they will have gonadal failure, like in testosterone, like in Turner syndrome, the females, these males have also primary gonadal failure, right? In Klinefelter syndrome. So we are done with
yeah, in this mark, actually, they have written that in a tall boy with pubertal arrest, you should rule out Klinefelter should be considered.
Yeah. Yes,
Not in
that
short
is why I
stature.
told you here.
Yes.
He has mentioned Klinefelter not for the short stature, it is for the delayed puberty. Okay.
So they are tall with delayed puberty.
Okay. Yes. Who was speaking just now? Shri Devi. Who was speaking with me? Dr.
Sunita.
Who?
No.
Sunita?
Sunita.
Okay,
Yes.
thank you. Can you repeat what you read from the mark?
Yes. In a tall boy with pubertal arrest, Klinefelter syndrome should be considered.
Okay, yes, thank you.